Select a blade. A 0 is typical for preterm babies and a 1 for term newborns. Attach it to the handle by holding the blade and handle parallel. Place the hook of the blade over the bar of the handle and pull downward along the plane of the handle. Turn the light on by clicking the blade into the open position to assure that the batteries and light are working. Check to see the bulb is screwed in tightly. To cut the endotracheal tube to length, remove the connector. Note that the connection to the tube may be tight, and then cut the tube diagonally to make it easier to reinsert the connector. Replace the endotracheal tube connector. The fitting should be tight so that the connector does not inadvertently separate during insertion or use. Ensure that the connector and tube are properly aligned so that kinking of the tube is avoided. Connectors are made to fit a specific size tube. They cannot be interchanged among tubes of different sizes. First, stabilize the baby's head with your right hand. Free-flow oxygen should be delivered throughout the procedure. Second, slide the laryngoscope blade over the right side of the tongue, pushing the tongue to the left side of the mouth, and advance the blade until the tip lies in the vallecula, just beyond the base of the tongue, or place the tip under the epiglottis and lift the epiglottis upward to expose the glottis. Third, lift the blade slightly, thus lifting the tongue out of the way to expose the pharyngeal area. When lifting the blade, raise the entire blade by pulling up in the direction the handle is pointing. Do not elevate the tip of the blade by using a rocking motion and pulling the handle toward you. If the laryngoscope is not inserted far enough, the view will consist mostly of the base of the tongue. To correct this, advance the laryngoscope down the tongue until the airway appears. If the laryngoscope is inserted too far, the view will consist of the esophagus. To correct this, slowly slide the laryngoscope out until the airway comes into view. If the laryngoscope is inserted off to one side, the view will consist of the glottis off the side of the blade. To correct this, gently move the blade back to the midline and advance or pull back the laryngoscope, depending on the landmark seen. Poor visualization of the glottis may also be caused by not elevating the tongue high enough to bring the glottis into view. Sometimes pressure applied to the cricoid, which is the cartilage above the larynx, helps to bring the glottis into view. This is accomplished by using the fourth or fifth finger of the left hand or by asking an assistant to apply the pressure. Suctioning of secretions may help to improve your view. The most common reason for unsuccessful intubation attempts is never adequately visualizing the glottis. Holding the tube in your right hand, introduce it into the right side of the baby's mouth, with the curve of the tube lying in the horizontal plane. This will prevent the tube from blocking your view of the glottis. Keep the glottis in view, and when the vocal cords are apart, insert the tip of the endotracheal tube until the vocal cord guide is at the level of the cords. Stabilize the tube with one hand and remove the laryngoscope with the other. With the right hand held against the face, hold the tube firmly at the lips and/or use a finger to hold the tube against the baby's hard palate. Use your left hand to carefully remove the laryngoscope without displacing the tube. Attach a ventilation bag or T-piece resuscitator to the tube, take steps to be certain the tube is in the trachea, and resume positive pressure ventilation with 100% oxygen. Colorimetric CO2 detectors change from purple to yellow in the presence of carbon dioxide. If the tube is in the trachea and there is adequate cardiac output, the color change should occur within 5 breaths.
Can someone listen, please?
Breath sounds should be audible over both lung fields, but decreased or absent over the stomach.
Don't hear it on the left.
52.
When inserting the stylet, it is essential that the tip does not protrude from the end or side hole of the endotracheal tube to avoid trauma to the tissues. The stylet is secured so that it cannot advance further into the tube during intubation. Connect the endotracheal tube to a meconium aspirator, which has been connected to a suction source. Occlude the suction control port on the aspirator to apply suction to the endotracheal tube, and continually withdraw the tube as you continue suctioning any meconium that may be in the trachea. Repeat intubation and suction as necessary until little or no additional meconium is recovered, or until the baby's heart rate indicates that positive pressure ventilation is needed. Insert an endotracheal tube into the trachea. Attach the endotracheal tube to a suction source. Apply suction as the tube is slowly withdrawn.